Radical belonging is the concept of inclusion for all individuals within a system that emphasizes and expands upon differences that serve as a source for increased understanding of humanity without degrees of entitlement. So providing a rich environment that does not exclude individuals based on ethnicity, social status, or academic achievements, but rather focusing on the individual and their unique contributions to greater understanding provides the foundation for group problem solving throughout shared trauma or traumatic situations such as COVID-19 pandemic. For the second question, a summary. Historically, degrees of entitlement, social status, and ethnicity have negatively impacted educational systems and healthcare communities, resulting in divisive team efforts, ultimately a poor understanding of the criticalness of engaging the individual. So it's critical to involve everyone within the group equally to provide a well-rounded solution to problems shared by all cultures and backgrounds. So everyone within a healthcare team provides a particular set of skills and experiences that are critical when providing efficient and patient-centered care to the general population. So it's important that the healthcare team maintains a high emotional intelligence that expands to team members and not just to patients. So inclusion within a healthcare team provides a broader and more patient-centered treatment plan that takes into consideration the skill sets of each team member.
All right, so our suggestions for radical belonging include recommendations at the organizational, team, and individual level. We think something that will work at an organizational level is interactive interprofessional grand rounds. The topic of these grand rounds would be determined by a survey asking employees about their concerns while working within the organization. This will serve to make people aware that they are not alone when facing certain challenges, as well as educate those who may need education regarding cultural awareness in the workplace. The goal of the grand rounds would be to emphasize that if we're talking about a particular issue, it is because a significant amount of concern was expressed via survey. This will hopefully develop a sense of community with those who have similar struggles and enlighten those who do not have that particular struggle on ways to alleviate or avoid adding to the struggle. At the team level, we think encouraging discussion of and about patients from every perspective of a caregiving employee would be effective at recognizing the essential nature of each team member. This could involve a campaign to encourage providers and caregivers at any level to bring up concerns during rounds. In the cases, for example, Jessie has connections with her patients, which is regarded as unprofessional and inefficient. We ask the question, what if instead this was considered an asset, especially when other providers have limited time with patients? This will serve to develop a way to educate all caregivers about what rounds are and how they can effectively take part in them if they feel it is necessary, encouraging a culture of gathering information, even if that information does not come from physicians, nurses, med students, etc. This will serve to promote the valuing of everyone in the data gathering process and incorporate perspectives of everyone in developing care plans for patients. Another way of implementing this same gesture is running the list post rounds and dividing out time for extra considerations that are not entirely focused on medical management, but incorporate cultural and social awareness of our patients with information gathered from many perspectives. On an individual level, we notice that a common theme among individuals in the cases demonstrates a concern about compensation, whether that be time or money. During times of crisis, such as a pandemic, employees should not feel as if they are acting inappropriately by questioning the time they put in versus the amount of compensation they get out, especially when extra time working, as well as increased difficulty and intensity of the care being administered, puts added stress and impacts life outside of work. Our idea to address this is implementing a survey that is sent out monthly to assess particular needs of team members. The survey would be free response. Items on the survey would evaluate how the company can compensate its team members by either allocating more time off or increasing pay to those who work more or are willing to work more. This would involve having a staff dedicated to interpreting the survey responses and building schedules and suggesting payment plans that are more individualized to what team members are concerned about.
COVID-19 had a significant impact on healthcare workers when it first hit and continues to leave its impact on the field still today. With many workers contracting the illness, burnout from being overworked, understaffed, and underpaid, and so many more factors inducing stress and negativity, it is no surprise that so many workers are leaving their position for somewhere else whether it be a totally different field or a place away from the front lines. However, from this pandemic came a kind of positivity and light that showed appreciation to healthcare workers who risked their lives working in this field at this time. There was a lot of support through words, donations of materials and food, and a unity that was never seen before. While this support is still somewhat here a few years later, it has slowly died down and we still see continued support without the shower of goods and material reward. During this time, there were many people affected by COVID-19 from a wide scope of diverse backgrounds. These marginalized communities became recognized for their work in the field, fighting the disease, as many workers on the front lines worked as doctors, nurses, and other significant occupations to help those who were sick. People from these marginalized communities weren't just workers at this time, and eventually a lot of them became patients as they contracted the illness, and we saw how different communities with differing backgrounds were affected firsthand. Everyone was prone to becoming sick, but those with higher stress levels, less resources to keep their environment clean, less access to important necessities, or were in overpopulated areas that made it harder to isolate or keep from infection seemed to suffer the most with the impact of COVID. Especially healthcare workers who gave their time and energy at work to be exposed to the virus and came from marginalized communities were at greater risk to contracting the virus and spreading it back home. With the impact COVID had on these communities, we strive to make a difference and show appreciation to those who gave so much to fighting and caring in the healthcare field. Our interventions will strive to build a positive and supportive community by being aware of the different backgrounds everyone comes from and how that impacts their lives at work. We want to create a space where everyone is provided the necessary resources that they need amidst outbreaks like those, and will open their minds and actions to make sure equity and justice is there for everyone and help our team members physically, mentally, and emotionally during these times.
In order to implement our proposal, it will help to generate a collaborative team effort among all parties to achieve radical belonging. There are three primary components that make up radical belonging, those being social belonging, which relates to care, respect, and appreciation for people, academic belonging, being collaborative, responsive, and anti-hierarchical, and democratic belonging, which utilizes critical consciousness and participatory action to create change. These three components in tandem with the results of our surveys to understand the healthcare workers' concerns and how we can use radical belonging to make an approach to impact our healthcare team and ultimately benefit our patient care. Unfortunately, many of our healthcare workers detailed in the case had good rapport with patients, but were also marginalized because of their race, ethnicity, or sexual orientation. The case emphasized how these roles connected with patients. So it will be important to utilize the results of our surveys and grand rounds and having collaborative meetings with participation from all levels of the organization to find a happy medium between those positive things relating to patient outcomes, while also having good cohesive team to kind of generate a good healthcare system. This will also help to respect cultures and value the different things our employees can bring to the table, which will also help lead to positive patient outcomes, patient satisfaction, and also satisfaction among our workers. By respecting these differences and being anti-racist, we can help to make sure our healthcare team from top to bottom feels valued and satisfied with their work by gaining and acting on worker feedback through the surveys to emphasize these areas which are critical to a positive work environment and ultimately benefiting patient outcomes is essential. Worker opinions should be valued, whether they're from management, the highest doctor, or the smallest support staff. And the healthcare team is only as strong as its weakest link, so identifying deficiencies and implementing changes to create a great work culture will help each person in the organization be heard, valued, and satisfied with their work. By interpreting results and continuously gaining feedback to pursue our short-term and long-term goals for improvement will keep us on the right track towards greater cohesion with the healthcare team.
Financially, the primary budget would revolve around data collecting and distribution of service. However, whenever there is money involved in charity or financial federal aid, there is usually the presence of abuse and corruption. Therefore, the biggest problem would be regulation and transparency. As a nonprofit service to promote equality, we should potentially count on federal subsidies like they utilize for BLM. But this would also mean the addition of government bureaucracy that would undoubtedly hinder aid to those who need it most. Additionally, the link between government and our service will usually mean that the victim is kept out of the conversation, which until the end usually limits transparency and encourages corruption because we won't be able to see what's going on behind the scenes. So therefore, I propose that our financial plan be to involve local and state subsidies because they have the greater capacity of the states to regulate behavior and enforce order within their territory for the betterment of the health, safety, morals, and general welfare of their inhabitants, while additional charity services from local populations can supplement our service. Furthermore, we can better compare results from different states in different locations to pinpoint the location where additional service may be required the most.
We will have a few different metrics in order to measure our success. To begin, our recommendations involve surveys that ask the team and individuals what they are concerned about, including topics that need to be discussed at grand rounds or areas where compensation needs to be addressed. By monitoring which topics are repeatedly being brought up, even after having grand round meetings, we can monitor in real time if there needs to be further discussion on a topic or if the session was effective. For example, if there was a discussion about the attitudes of physicians toward other specialties discussed at grand rounds, but the surveys over the next week or month continue to express that this issue has not been resolved, we will understand that our original discussion was not successful and further investigation and discussion is required. For a more formal evaluation, after every grand round meeting, a QR code will be able to direct participants to a quick survey asking, was the session helpful, why or why not? This survey will act as an attendance quiz and also will give feedback for the sessions. Survey burnout is a true issue with implementing programs like these, but they are vital in understanding what needs to be addressed. By making the survey short with room for elaboration if the individual desires, there is less likely a chance for dread over providing feedback. By combining it with the attendance survey, two needs can be addressed with one action from the individuals. There will also be an option to make the survey questions anonymous while still taking attendance if the individual would like. By having it be completed directly following the event, the information is fresh and participants are less likely to forget about filling it out, which can happen during a busy day or if emails start to pile up. Finally, we will have a survey that will assess the satisfaction of all the individuals. This will happen every 6 months. This will involve questions on whether the individual is satisfied with the job, with the team, with the workplace environment, and with compensation, and also how well they feel the organization is addressing their concerns. Since this quiz will be longer, we feel limiting it to twice a year will decrease the amount of burnout while still giving time for individuals to express how they're feeling. More immediate concerns can be addressed using the short surveys discussed above, while overarching issues can be addressed during these longer surveys.
So we believe our ideas are sustainable and scalable to other healthcare settings and organizations. The role of grand rounds and surveys in healthcare settings other than the hospital, such as nursing homes, outpatient clinics, and pharmacies, will be sustainable and scalable with tweaks in the implementation. In these settings, informal weekly meetings with the entire team would welcome discussion about gaps in care and optimizing quality of care. In fact, this idea may be easier to implement in these healthcare settings compared to the hospital due to smaller healthcare teams and easier communication, whereas in the hospital, it may be more difficult to assemble individuals from all departments, let alone representatives. Surveys would still be able to be virtually distributed amongst the employees, and as previously mentioned, concerns that are brought up in these surveys could be talking points for the subsequent weekly meetings. Additionally, employees should have the option to meet one-on-one with a designated employee, whether that be the office manager, physician, or someone else who is integral to the workplace operation, if they are not comfortable bringing up their concerns in a group setting. Issues that could be addressed in these personal meetings would be issues that the workers in the given cases are experiencing, such as burnout, pay dissatisfaction, or harassment. However, one element that could be integrated more overall into institutions is peer-to-peer discussion rather than discussion driven by a hierarchical structure. In hospitals, though there is a hierarchy with regards to who makes the final decision, decisions are ideally discussed as a team, and a culture of teamwork should be emphasized in all levels of care. The aforementioned metrics of success could also be applied in these settings through surveys as well. Therefore, incorporating a welcoming environment for every member of the team to voice their opinions or concerns will go a long way to kindling a culture of radical belonging and maximizing the potential of each individual in the team, regardless of the healthcare setting. And that concludes our presentation. Thank you.
So I'm Cody Stiglitz. I'm a physician assistant student. This project really opened my eyes into the importance of understanding the critical role that everybody plays as a team. Throughout this project, we all played a different role in doing different parts of the project, and it just goes to show too how important it is that everybody works together. I felt like we had really good communication. We were all very responsive, had a group chat going to stay in contact. So overall, it was a good experience.
My name is Nick McDonald. I'm a third-year med student, and I enjoyed this project because I kind of got to learn about radical belonging and gaining 7 different perspectives kind of what radical belonging means to each one of our team members. And it was also just good to collaborate and brainstorm ideas and kind of mimic the process that we'll most likely be introduced to when we fulfill our respective roles as we progress in our career. So it was just good to enact that and kind of gain everyone's perspective and kind of implement everyone's ideas into one project and learn about radical belonging. So.
Hi, my name is Ivana, and I'm an accelerated nursing student. I thought this project was really interesting, and I got to learn a lot about what each profession did and see firsthand how the care of the patient was impacted by each profession. And I think that we work really well together in our communication and collaboration, and it really is very helpful as to use this as practice for later on when we're actually practicing and have real patients.
My name is Michael Isles. I'm in my final year of physical therapy school. And this project was especially rewarding for me because in undergrad, I was a public health minor. So having the opportunity to work on a case about like health disparities and things like that was really rewarding, especially with the opportunity to work with different people in the interprofessional team, like med students, nursing, pharmacy. So just kind of seeing how we can all collaborate and bring different perspectives and things together to like get something done and make a change for even if it was just a case, it had a lot of real world applications that hopefully we can all apply once we graduate and are in the actual healthcare field.
Hey, I'm Madeline, a third-year medical student, and this project kind of showed me like how important it is for a team to be able to adapt to different situations, whether it be technical difficulties, which we did go through. The team was able to kind of meet and just figure things out as it happened. So it was great to be able to work with a team that was able to do that.
My name is William Chua. I'm also a third-year medical student, and this was a really, I think, unique experience because it was basically the only class that were all, specialties and all medical fields. They were able to get together and work on a project, and we can all see everyone else's perspectives, outside of just the hospital setting. And I think it was a really valuable experience too, as others said, how this can be applied to real life, and how for the rest of our careers we'll be working with so many different people from so many different backgrounds and experiences, and thought this was a really eye-opening experience for us as well.